Perfect. So we are live. So welcome everyone. It's a great pleasure today to have Dr. Jonathan Leipsic today in our CT and MRI meetings. I'll give a brief introduction, even that everyone knows him. Dr. Leipsic is the chairman of the Department of Radiology for Providence Healthcare and Vancouver Coastal Health, and the vice chairman of research at UBC Department of Radiology. He's a professor of radiology and cardiology with the University of British Columbia. Dr. Leipsic is also a Canada Research Chair in Advanced Cardiopulmonary Imaging. He has over 590 peer-reviewed manuscripts, over 300 scientific abstracts, and he's the editor of 2 textbooks. He speaks internationally on a number of cardiopulmonary imaging topics with over 150 invited lectures in the last 4 years only. He's also the past president of the CCT, and he was awarded its gold medal in 2019. He was recently named in the prestigious top 1% most impactful scientists by a designation by the Web of Science in 2019 and 2020. He'll be talking to us today about non-invasive physiology using CCTA, from diagnosis to therapeutics. Thank you, Jonathan, for joining us.
Thank you so much, my friend. Let me just close my my email so it doesn't ding repeatedly. It's a real honor to be here to start. It's an amazing set of lectures that you and the team at Montefiore put together with Azim and everyone, and to be speaking this Friday with all of you and so many of my mentors and colleagues and friends on the call is a real privilege. So thank you again. I'm going to spend the next 40 minutes really talking about the centrality of the role of cardiac CT, try to make the case that the guidelines should shift, that cardiac CT should be considered as a first-line test for patients with suspected but not yet confirmed coronary disease. And then I'll try to pivot into the potential role for physiology, not only to guide diagnosis, but to help inform revascularization decision-making. So I do have some disclosures. Most relate to the core lab work. We support a lot of structural heart disease trials. I take no compensation for that. I do provide advice to HeartFlow as a consultant, and so that's salient to this talk. And I also have a research grant from GE Healthcare, who are makers of cardiac CT. So, you know, I know that Professor Berman is on this call, and he's a pioneer of both nuclear stress testing as well as cardiac CT. And I've learned from him and so many others over the years that you really should be using testing to help inform and answer the clinical questions at hand. And so when we're confronted with a patient with symptoms suggestive of possible or probable angina pectoris or of coronary disease in a patient without yet that diagnosis, I would posit to you that CTA should be considered as a first-line test for a number of reasons. The first is that it has, as an anatomical test, it has superior diagnostic characteristics as it relates to the diagnosis of and exclusion from anatomical coronary disease. These are data that go back many, many years, over a dozen years, in fact, highlighting that even on 64-slice cardiac CT, that the diagnostic performance of cardiac CT is superior as it relates to answering the question, is there an LAD stenosis or not, than other non-invasive tests. In addition, and as you all know, and as I'll touch upon in a moment, it provides incremental value beyond just the detection of stenosis through the opportunity to uniquely and non-invasively identify atherosclerosis, which is, of course, the very disease that causes incident myocardial infarction, thereby creating an opportunity for us to yield an earlier diagnosis and help guide medical management. More modern data would support that the strength of cardiac CT as an anatomical test has only grown. These are data from John Mancini, led this analysis from the Ischemia trial. We supported the CT core lab work with Jim Min and Matt Budoff and John. And what we learned through the trial is that anatomical assessment with CT is not perfect as it relates to the correlation with invasive angiography, but it really provides remarkable anatomical detail and fairly good diagnostic performance, even in complex coronary disease. So these are the ischemia patients with confirmed moderate to severe abnormal ischemia tests. And what we can see here is the agreement between CTA and invasive coronary angiography was 97%. as it relates to left main disease, with fairly good correlation as it relates to the extent and severity of anatomical disease, even in these most complicated of anatomical situations. The second reason I think that CT should be considered as a first-line test for suspected but not yet confirmed coronary disease is its tremendous prognostic utility. As I always say, if I were to give this talk a dozen years ago, people would say to me, well, we recognize CT as an anatomically accurate test, but I really need to rely on my stress testing. I need to rely on the treadmill. I need to rely on the SPECT test because I need prognosis. And again, it's largely because of the great work that Dan Berman has shared with us over the years, that the nuclear stress test we knew was very powerfully prognostic as it relates to predicting risk of downstream mortality and major adverse cardiovascular events. But through the significant efforts of many, many people, the CONFIRM registry and many other registries, we've seen over the last decade that cardiac CT provides incremental, perhaps, prognostic information even beyond traditional stress testing. I could go on for an hour on prognosis from CTA, but I'm just going to share two slides. This slide from the PROMISE trial published by Udo Hoffmann in 2017. What we see here on the left are those patients who underwent CT, 5,000 Americans. On the right, 5,000 Americans who underwent largely SPECT testing. And what you can see on these Kaplan-Meier curves are two incremental pieces of information and a prognostic value that are yielded from a cardiac CT. The two lowest Kaplan-Meier curves, if we look at them here on the CT arm, the x-axis is time, the y-axis is percentage of patients with events. And what you can see here is the lowest curve is those without any atherosclerosis. The event rate through 3 years is under half that of a negative SPECT. So the warranty period of a truly normal CT is longer, and the event rate is significantly lower than a negative stress test. In addition, if we look at those patients with mild non-stenotic atherosclerosis, the relative risk of those patients uniquely identified by CT, identifying non-stenotic plaque, not ascertainable on any other non-invasive test, what we identify here is that those patients have a threefold higher hazard for downstream events than those patients without any atherosclerosis. And interestingly, this threefold hazard, as is noted in the PROMISE trial, is exactly the same that was published from the CONFIRM registry. In addition, if we look at those patients with a severely abnormal CT, you can see that the relative risk of downstream events is tenfold as compared to those without atherosclerosis. And when you look at those with a severely abnormal SPECT test within the PROMISE trial, the relative risk is only fourfold. This is because the absolute risk of someone with a negative SPECT is not anywhere near as low as a negative CT. In addition, as we saw in the Ischemia trial, there are many patients who have severely abnormal stress tests that are found to have only modest anatomical coronary disease. This is what we saw in the Ischemia trial. 16% of patients with moderate to severely abnormal stress tests did not even have a CT stenosis of greater than 50% when those CTs were done in a blinded fashion. So I think that mutes or reduces the relative risk associated with a severely abnormal stress test. On the other hand, when we call a severely abnormal CT, what we know is that maybe we call triple vessel disease, and at angiography there's double vessel disease, and maybe even on occasion only single vessel disease. But it's exceedingly rare that those patients don't have a single anatomical stenosis. So I think even in the single analysis, we see real opportunities of CT to inform prognosis, even beyond traditional robust stress tests. As well, if we look back to the last ACC, the virtual ACC in Chicago, David Marin presented data from the Ischemia trial, an analysis led by Harmony Reynolds, showing that the extent and severity of anatomical disease adjudicated by CT, not by invasive angiography, but by CT, had a close and tight relationship with incident mortality in a fashion that the extent and severity of the stress testing abnormality did not. So another example of how CT informs prognosis, not just reasonably, but perhaps better than any other non-invasive test. So I think a really important message as cardiac CT is adopted more and more routinely in practice in the US. Beyond stenosis, of course, and I know you've had some very elegant lectures from people like Armin Zadeh and others, so I didn't focus this talk particularly around atherosclerosis, but we know CT offers us much more than just the presence or absence of anatomical stenosis or the presence or absence of atherosclerosis. In routine clinical practice, we can use measures such as the segment involvement score, the number of segments of plaque, the plaque morphology, is there low density plaque, is there adverse plaque features, and so on. And these things can help inform prognosis even beyond the presence or absence of anatomical stenosis. Just this year, earlier this year, the SCCT guidelines on atherosclerosis led by Professor Shah and Narula were published, and I think it really provides a nice roadmap of where we need to go as a field and where we're at currently. What I always tell our fellows is that we need to, until we have quantitative plaque measures that are routinely integratable into our practice, we need to make sure that we at least offer all the richness that we can from the CTA. Number of lesions, are there adverse plaques, what is the overall plaque morphology, and how extensive is the atherosclerosis? Because we know through extensive prognostic papers as well as constantly evolving literature around atherosclerosis, that patients that have premature plaque, more extensive plaque, and more adverse plaque have a heightened risk if left untreated. Beyond that, the other reason why I think CTA should be considered as a first-line test for patients with suspected but not yet confirmed coronary disease is because I think it informs medical management in a fashion that improves outcomes. We've learned this from large registries, but also from the Scott-Hart trial. This is the 5-year outcomes of Scott-Hart, really highlighting that patients who are treated on the basis of CTA, in addition to stress testing, observed a 40% reduction in myocardial infarction and cardiovascular death. Now, many people, when they saw these data, they question, how is it possible? You know, the absolute difference in statin usage was not that profound. In fact, Professor Call wrote an editorial to JAMA Cardiology about this. But I think what most people don't recognize is that when you look at the 36% difference in statin use, you may say, how can we have such a profound treatment effect? But the key here is it's who is treated. If we look at this analysis done by Professor Newby's lab, published in early last year in JACC, you can see, if we look at the lower half of the figure, on the x-axis is risk. On the y-axis is the percentage of patients who are being treated with statins. Gray are those without atherosclerosis. Purple are those with non-stenotic plaque. Orange are those with stenosis. What you can see here is in the CT arm, if patients had plaque, even if they had a low risk of having an event according to the population-based risk scores, the cardiologists were thoughtful and said, you may not have a high risk of an event, but you have the disease that causes incident myocardial infarction. I'm going to treat you. And I think it's really this personalized approach to medical therapy that offers the real potential of CTA. We've seen that not only in Scott-Hart, but we've seen that in also other observational studies. We've seen that in the West Danish Heart Registry recently, showing that CT-guided medical therapy reduces downstream events. And I think it's very much because of this titration of medical therapy, not based on population-based risk of having the disease, but based on the personalized identification of the extent and severity of atherosclerosis. As well, and actually, again, going back to the Eisner trial from Dr. Berman's work, where he taught us that in a randomized fashion, that when we see atherosclerosis on the calcium score, patients were more likely to adhere to medical therapy. And this was the first really to really highlight that. But I think that's what we saw as well in the other randomized trials, that if we look at PROMISE, the utilization of medical therapy in the CT arm was significantly higher than the functional testing arm. And also there was greater adherence to that medical therapy. So I think that the message remains clear that it's titrating medical therapy based on the individual phenotype of atherosclerosis and extent is powerful with regards to reducing risk. And it's also powerful to the patient to understand why they're being treated, rather than simply telling them that across a population of patients, we think you may be at a heightened risk of having an event. All of these data led to, of course, the ESC coming out with a class 1 indication for the role of cardiac CT, and I hope that in the coming few months that we see the same from the ACC/AHA, so that you can really explore the use of cardiac CT in a more robust fashion across the centers in the US. We do 25 coronary CT angiograms a day here in Vancouver, and it's really shifted our practice and very much a clinical routine. Now, I hope I've made a case that CTA should be considered as a first-line test for patients with suspected coronary disease. But one of the challenges we've faced for many, many years as it relates to the integration of cardiac CT is that we couldn't ultimately answer this final question. You know, if I diagnose a mid-LAD lesion, I say it's 75% stenosis, which of course we don't have the spatial resolution to do, but say I even call it a CAD-RADS 4 lesion, 70 to 90, and I send the patient to the cath lab and my interventional colleague says, Jonathan, you're spot on. It's a 75% stenosis in the mid-LAD. She cannot stent that lesion appropriately without having confirmed abnormal functional significance, either invasively or traditionally, historically, with non-invasive stress tests. So this has really been a limitation of CT as it relates to not just diagnosing coronary disease, but then informing revascularization for the same reasons why anatomy alone can't guide revascularization invasively. Over the last 15 years, of course, we've seen a real penetration of invasive physiology in clinical practice. This is the 5-year outcomes of 5-year outcomes of FAME2, where patients with abnormal physiology defined by a hyperemic FFR below 0.8 were either randomized to medical therapy or revascularization. And what you can see here is that those that were left on medical therapy and not treated despite abnormal physiology were exposed to a heightened risk of urgent unplanned revascularization, as well as also a heightened downstream of myocardial infarction rate. And the corollary of this also held true. If the FFR was above 0.8, the patients derived no benefit from revascularization. In fact, they derived harm from revascularization. So really the clinical utility of invasive physiology to really help inform decisions around revascularization in a very granular and effective way has become increasingly clear over the last really decade. Similarly, not only has that been shown in randomized trials, what we've seen is in large registries. This registry is from the Northern California VA, published by Bill Fearon and his colleagues. And what you can see here is in an observational study, at least, patients revascularized by physiology had lower mortality than those revascularized by angiography alone. And finally, as a good Canadian, I had to share a bit of Canadian data. This is was presented, I think, at AHA and published at the same time in JAMA from the group from Sunnybrook in Ontario. This is 500,000 Canadians, and what you can see here is very similar to the randomized data. Not only does abnormal FFR identify patients who derive a benefit from revascularization, you can see their event rate is lower when revascularized, but the opposite held true again. If you have physiology that is above the 0.8 threshold, lesion-specific physiology that is above the 0.8 threshold, the patients derive harm from revascularization as compared to being left alone. So clearly physiology is the invasive gold standard for the determination of whether or not to stent a lesion. And this is something that, of course, we've understood is of clinical utility, but have been limited in providing that information from CT alone. The reason we're limited, of course, is that there's a fundamental disconnect, or I wouldn't say disconnect, but an inconsistent relationship between anatomy and physiology. We've known this for many, many years, where anatomical stenoses that are high grade may not have abnormal physiology. And the corollary of this holds true as well. You can have modest anatomical stenosis and abnormal physiology. Obviously, a high-grade lesion is more likely to be physiologically significant, but 25% of 70 to 90% lesions may not be. And so we simply can't rely on diameter reduction to determine whether or not the lesion itself is causing abnormal lesion-specific physiology. So, I know many of you are using FFRct. This is a tool that I've been investigating with many, including, many, many years ago with Jim Min and Dan Berman and Matt Budoff and others, looking at the potential of integration of computational fluid dynamics, as well as artificial intelligence to actually derive a pressure map that allows for patient-specific physiological flow models, allowing for the adjudication of physiology in a lesion-specific fashion. Now, I don't have the time to delve into it, and I'm not an engineer, but I would tell you that there's a lot of science behind the integration of, or the development of FFRct. As it relates to the computational fluid dynamics component, this is clearly a well-established field. It goes back to, Newton's time, and then fluid dynamics beyond that into the CFD space. The challenge, of course, was that we didn't have anatomical models that were patient-specific in a non-invasive fashion. Now, with robust cardiac CT, I think we have that. We have the root of the aorta, We have the size of the coronary arteries. We have patient-specific branching patterns. We know from Murray's law that there's a consistent relationship between the epicardial coronaries and its branches. We know, for example, also that the coronaries, there's an inverse relationship between coronary size and microvascular resistance. We know that patients with thicker heart muscle have more resting flow unless they have angina at rest. And that we know that blood is Newtonian fluid, at least as it relates to the central flow within the coronary arteries, so that all the laws that govern non-compressible fluids can be applied to blood. Now, two issues at play. The induction of hyperemia is modeled. So the modeled hyperemia is an aggressive model. If the patient does not achieve hyperemia invasively, then the FFRct will generally trend to be a lower value than invasive FFR. But I think the other opportunity that we've seen over the last decade, and I've heard through many of the talks at the Monty Hart lectures, is the penetration of artificial intelligence. And I think that's provided an additional opportunity to not only integrate CFD, but to make the anatomical extraction of this data more robust by using invasive data as well as more and more CT data to make sure that the anatomical segmentation can be more robustly and more quickly extracted, allowing then for a more stable physiological flow calculation. So how accurate is FFRct? Well, what we've seen in the last three accuracy studies, whether it was the NXT trial, the sub-study of Pacific, or recently the analysis done by Rob Safian and Gil Raff and others from Beaumont, is that its accuracy as compared to invasive FFR is about 87%. And when we look at the sub-study of Pacific, where patients underwent oxygen label water PET, SPECT, and CTA, you can see that the diagnostic performance characteristics of FFRct is superior to other tests. But what I would argue is that this even belies the real opportunity here. I think PET is a tremendous tool. We don't have it here in Vancouver, but we're certainly advocating to get it. And you can see on this PET, the diagnostic performance in Pacific was really quite high. But what I would highlight here is I think the real opportunity of this triaged approach of CT and then selective FFRct is that it allows you to really integrate not only the physiology, but the anatomy, allowing you to send a patient to the cath lab with an understanding of anatomical stenosis, grade and severity, lesion length, plaque morphology, and then lesion-specific physiology, rather than, as we see in this case with the PET, we can say the LAD is abnormal, but you can't really inform your interventional colleague what is driving this flow disturbance. Is it a proximal LAD lesion? How long is the lesion? What is the plaque features? What is the translesional pressure loss? So I think there's unique opportunities through this CT FFRct strategy. So how do we interpret this data? Well, when we integrated it into our clinical practice, I realized that it was much more challenging at first than what I saw in the accuracy studies. The accuracy studies were simple because there was an invasive FFR, there was a blinded analysis, there was co-localization of the pressure wire, and either the analysis was right or wrong. Of course, in the clinic, we don't have an FFR to tell us where to measure because we're actually determining what should be the downstream treatment decision-making for said patient. So on this study here, what we tried to highlight was that the lesion-specific physiology that I highlight here at 0.83 is really the key value as it relates to determining whether or not we should send the patient to the cath lab. If the value is above 0.8, if there's no meaningful translesional pressure loss, as in this case where the delta is only 0.07, these patients should not go to the cath lab. This patient has negative lesion-specific physiology. On the other hand, people will say to me, well, does that mean this 0.70 is just a false positive? And I don't think it is. I think it informs, in a significant way, it provides us an understanding of the patient's vascular health. We saw from a great analysis actually from Cedars-Sinai not long ago, published in JCCT, where they looked at the predictors of nadir abnormal FFRct, and they found that totality of plaque was a strong correlate with low nadir FFRct. So I think this value of 0.70 is telling us this patient has poor vascular health. Either they have low coronary volume to mass, they have diffuse plaque, but they're not healthy. But that is not a value that should be used to guide decision-making around referral to the cath lab. You may say, how do I know that that's the case? Why should we be using the lesion-specific physiology? Well, I think this data from Elvis Cami and Rob Safian from Beaumont really helps reinforce that statement. If you look at their real-world experience of patients that went to the cath lab with anatomical stenosis in the 40 to 90% range, you can see that when they adjudicated physiology distal to the lesion, the diagnostic performance compared to invasive FFR was 88%. So I think it really highlights again, if the decision or the question is, should I send this patient to the cath lab? You should adjudicate physiology distal to the lesion. And if that lesion is above 0.8, the patient should be deferred. Now, if you do integrate this into practice, it is important that you work closely with your interventionalists. And I know that's very much the model that we've tried to do in the TAVR space over the years. And I know very much at Montefiore what you are working as you work. And I think when it comes to the coronary analysis, I think it's time that we do more and more of this as well. We can't just simply send the patient to the cath lab with a report saying, go to the cath lab and let them figure it out. We need to partner with them, especially around complex disease, to better understand the strengths and also the weaknesses of our non-invasive tests, but also enable our interventional colleagues to really explore the utility of these non-invasive data to help inform and help them plan their catheterization and revascularization, which I'll touch upon now. Now, if we send a patient to the cath lab and we tell them that there's abnormal physiology or normal physiology, and we don't tell them where, and we don't provide them that anatomical detail as to the location, and they do an FFR, they can easily tell us that we had a false negative in this case if we reported 0.85, and yet you can see the agreement is actually very good along the length of the vessel. So co-localization and providing clarity as to the location of the physiological flow assessment is so important. In addition, when we send patients to the cath lab, if you're a non-invasive imager, you have to understand that FFR is an excellent gold standard, but it has to be done in a thoughtful way. Different labs have different expertise, and I think it's important that we work with our interventionalists to understand not only co-localization of the pressure wire, but understand how to appropriately adjudicate physiology. This is from Greg Stone's lab, highlighting that many FFR tracings that are submitted to core labs are deemed inadequate as it relates to quality, either due to ventricularization of the pressure, pressure drift, inadequate hyperemia, all of these issues that are at play. And this was even highlighted recently in a study just at the time of AHA, again, called Disengage, highlighting that if the guide catheter is engaged, you can significantly artificially inflate your FFR by dampening the flow. So these nuances are important, and they're certainly important that for us as non-invasive imagers that we understand so that we can engage in these discussions when there are disconnects between our non-invasive imaging and the invasive data. And it's also important, obviously, for our invasive colleagues to understand these limitations as well. So this is how we read the CTs. We look at the lesion-specific physiology, the FFRCTs. If the FFRCT distal to the stenosis is above 0.8, we defer. If it's below 0.75, we send to the cath lab. If it's in the gray zone, we look at something called the delta FFRCT. So how much pressure is lost across the lesion, as well as location. Is it a proximal lesion, and so on. And then we also look at plaque. And one of the reasons we look at plaque is because of this interesting data from the 3-vessel Friends study published by Akasaka and Quan Ku back in 2019 in JACC. What you can see here is that in the gray zone of physiology invasively, 0.75 to 0.82, when the patients had adverse plaque features on CT, low attenuation, bulky plaques, positive remodeling, these patients had a higher event rate than those that had even low FFR who were revascularized and had a significantly higher event rate than those that had a gray zone or normal FFR without these plaque features. So I think it's another opportunity for us as non-invasive imagers to not only provide the physiology, but also to integrate some of the richness of the plaque features that we see to help inform decisions around revascularization, particularly in the gray zone. So how has this impacted our clinical decision making? Well, what we've seen is that the lower the FFRCT, the more likely the patient is to go to the cath lab, and the more likely the patient will be revascularized. In the advanced registry, 5,000 patients, if you went to the cath lab when the site said go to the cath lab, the physiology is abnormal and there is a stenosis, 83% of those patients were revascularized. As well, I think one of the opportunities of a negative FFRCT is that if you have a negative FFRct, the likelihood that the patient will cross over and require revascularization owing to ongoing angina despite medical therapy is very low. In advance, only 1% of patients were revascularized in a negative FFRct after 60 days. And in the first 60 days, only 6%, largely based on historical reliance on stenosis. But I think the message is similar to the invasive data. If you have a negative invasive FFR, a negative FFRct, these patients likely get adequate symptom relief with medicine alone. As it relates to heart events, we saw that the patients with a negative FFRct had a very low event rate with only 3 myocardial infarctions in 1,600 subjects out to 1 year. And there's a larger meta-analysis that is to follow from Bjarne Norgard looking at patients out to 5 years. And I'm aware of data, also a sub-analysis of the Discover Flow study coming from Quantifying, 10-year follow-up data, which will be quite interesting, presented at PCR. Last 2 things before I pivot to planning revascularization. I think it's important that we recognize that in a randomized trial, FFR was used in a binary fashion, as all randomized trials require a binary cut point. But in clinical practice, as we've seen from Niels Johnson, that invasive physiology is a continuous variable. So in this era of post-ischemia, if we have a lesion that, for example, in the mid-LAD, single vessel disease, and the FFR is 0.79, 0.78, it's probably not unreasonable to give the patient medical therapy, and they'll likely get good angina relief because of the gray zone physiology and are unlikely to be exposed to a significant hazard. On the other hand, if the physiology is significantly abnormal, if it's 0.65, 0.67, those are the patients I'm quite confident that are the ones that are crossing over in the ischemia trial with ongoing refractory angina. Those are the patients that we've seen, if we look at the physiological data sets, that are exposed to increased risk of spontaneous MI. So I think in practice, we need to be thinking of FFRct in a similar fashion. These are data from Manesh Patel, the 1-year advanced data, and then on the right from Abdul Dahid from Monash from the 5-year NXT data, again highlighting that the lower the physiology, the higher the risk. Finally, when it comes to what stenosis we use FFRct, we really know that there's an inconsistent relationship between anatomy and physiology in the 40 to 90 range. But I think what is a missed opportunity is the use of physiology in the 70 to 90% range, in my opinion. And that's because I think we've traditionally thought of CT as just a binary, go to the cath lab or not. But I think now as we're moving towards more planning and informing revascularization, there's a real opportunity in these higher grade stenosis to not only avoid cath in 1/4 or maybe a third of patients who have negative physiology despite a stenosis, but also to send the patient to the cath lab rather than simply the information saying, hey, there's a stenosis, go figure it out, determine whether or not they need to be revascularized, go do physiology. We can send the patient to the cath lab with anatomy and physiology, allowing them to be appropriately revascularized in accordance to the updated ACC-AHA data variables for the NCDR. And that's our database in BC mimics the NCDR such that now with anatomy and physiology, we offer the opportunity for appropriate revascularization in a fashion where if I were to just simply send the patient to the cath lab with a CT, my interventional colleague cannot stent a mid-LAD lesion without confirming functional significance. So I think it's an opportunity to aid our interventional colleagues in facilitating more efficient use of cath lab resources. Before I pivot to a planning intervention, I will highlight some recent health outcomes data and cost effectiveness data. This is from Udo Hoffman and Pam Douglas from the Promise Health Economics analysis published in JAMA Open late last year. And what you can see is that CTA dominated the stress testing pathway as it relates to health cost effectiveness, and even that was dominated further by a triage CTA FFRct pathway, which resulted in lower cost per quality. As we can see here, the cost per quality was significantly lower for CTA and FFRct as compared to CTA alone, which was cheaper than functional testing alone. So modeled data but I think important data as it relates to highlighting the potential health economics opportunities of this pathway. Clearly, we need randomized data. The PROMISE trial is almost completed enrolling, being led by Pam Douglas, and this will be incredibly important for our field, I think, to further understand the opportunities around this diagnostic pathway supported by CTA and FFRct. There are a number of areas of clinical investigation. One is in the ER. The ER, what we've seen is that from the Beaumont group is that FFRct can complement CTA in selected patients and help inform cath lab referral, improve the PCI to ICA ratio. I think this is an interesting opportunity for us to continue to explore how we can use physiology to better inform rapidity of diagnosis and referral to the cath lab. We've also seen in patients with peripheral vascular disease that there's an opportunity to use CT in these high-risk patients. It's complemented by FFRct to better identify patients at potential risk of downstream myocardial infarction. And I think another area of real opportunity is to explore the differences between men and women as it relates to not only atherosclerosis, but also physiology. This is a nice analysis done by Tim Fairbairn, published in JACC Imaging, highlighting that women have higher FFRct values than men at every threshold of stenosis. And while in the invasive literature, this has often been ascribed to being related to microvascular dysfunction in women, resulting in poor hyperemic reserve and therefore higher FFR values, at least according to this advanced analysis, some of this may relate to higher coronary volume to mass in women, where they have smaller coronaries, but their myocardial mass is even lower, such that their coronary volume extracted from CT is relatively larger relative to the myocardial mass, resulting in a more better resting flow and being less sensitive to anatomical stenosis as it relates to abnormal hyperemic pressure. And that's what was shown very nicely here. You can see smaller coronary arteries in women, but relative to their myocardial mass, they have higher VM, and that results in higher FFRct values across all thresholds of stenosis, and may help us better understand why these fundamental differences between FFR in men and women. So I think exciting and interesting opportunities to continue to explore about functional and anatomical differences between men and women. Malcolm Anastasis recently published the clinical utility of FFRct in older and younger patients and showed that it was as clinically useful in patients over 65 as patients under 65, at least in the advanced registry. And then finally, an area of real interest of mine is exploring the potential opportunity of non-invasive physiology in patients with aortic stenosis. Obviously, we need a lot more data than this, but this is at least mouth-watering, as I say, or thought-provoking data from the Monash group from Brian Coe and Abdullah Dahid as well. You can see in these patients who had aortic stenosis, they showed feasibility of not only doing CTA, but of doing FFRct with reasonable accuracy compared to the invasive gold standard. Small sample, but nonetheless, I think an interesting opportunity to explore using, for example, CTA and FFRct to evaluate not only proximal coronary disease, but as we move to lower risk patients, to evaluate the entire coronary tree before TAVR to avoid an additional invasive angiography, but while providing a complete evaluation of the anatomy, particularly with the concerns as it relates to coronary reaxis post-TAVR. Now, for the final 7 or 8 minutes, I just wanted to close on what really is exciting to me is this opportunity to imagine that for the first time we have a tool that can not only inform decisions around invasive angiography, but can actually help plan coronary intervention. And so what I like to say is that we wouldn't go do a TAVR without a non-invasive evaluation of the annulus. And yet for many, many years, patients have historically gone to the cath lab on the basis of clinical assessment, nuclear stress tests, a treadmill, auscultation of the chest, and our interventional colleagues do a cath and find no coronary disease and are frustrated, or they find the most sinister coronary disease they've identified in a week, and they have to make an ad hoc decision about complex revascularization. And I think that's just a bridge too far. It's just too complicated. This is an incredibly challenging disease to treat, and in a busy cath lab, I think the times to make those decisions ideally would come before the time of invasive angiography. And the reason I say that we need to help our interventional colleagues is that the data would suggest that complete revascularization is simply not happening frequently enough in the large interventional trials. These are data from Syntax, but I know that similar data will evolve and come out from ischemia, from the ischemia trial, that incomplete revascularization happens far too often. And we know that incomplete revascularization is associated with not only unplanned urgent revascularization downstream, but also in a recent meta-analysis, a 35% higher downstream myocardial infarction rate. So treating patients effectively, properly, and completely should be really a goal. Now, how can CT help? Well, one of the first and most basic ways that I think we ignored for many years was trying to really provide fluoroscopic angles could help inform optimization of visualization of complex anatomical areas of the coronary tree, such as the left main or left main bifurcation or LAD bifurcation. This is work from a group in Krakow and also McGill, Nico Piazza's team, showing us very similar to how we evaluate the aortic annulus. We can anatomically extract data as it relates to the left main, helping provide that guidance. You could imagine not only in the setting of native coronary disease, but perhaps post-TAVI, providing that richness of the fluoroscopic angle to optimize cannulation at the left main. Here's an example from the figure and an example also from a coronary CT angiogram, FFRct from our site, highlighting that we can profile the LAD stenosis very nicely at LAO 15, cranial 45. So you may say to me, you know, is this really necessary to develop these volume rendered images and provide these fluoroscopic angles? You know, can't the interventionalists just optimize visualization of these lesions based on their years and years of experience? Well, this case was lent to me by Carlos Collet from Aalst, Belgium, and he highlights to me, this is his typical working angle, LAO 19, cranial 31. Here's the lesion, it's 3.6 centimeters. Now, I know at academic centers like Montefiore, where you have really amazing interventionalists doing a lot of invasive imaging, you would perhaps use OCT or IVUS to look at the length of the lesion as well. But let's say we're just looking at the angiogram to determine how long we want to stent. Look at, if you went to the cath lab, and you didn't use the standard fluoroscopic angle, but you use the angle that the CT provided you, you would see that this lesion is not 3.5 centimeters long. This lesion is in fact 4.5 centimeters long, highlighting that going to the cath lab with a fluoroscopic angle from the CT provides you an opportunity to better understand not only the optimization of the visualization of the lesion, but the lesion length, and help inform the need for revascularization decision-making. As well, we know that CT plays a very strong role as it relates to CTO recanalization, but how about lesion prep? Whether we're doing lithotripsy or rotablation, there's no randomized data, but it certainly makes intuitive sense. We have this information. The calcium is there. We can look at features of calcification as it relates to prepping the lesion. We know that no two lesions on CT are the same, and we have these non-invasive evaluations that can help us understand the lesion-specific anatomy and plaque morphology to help inform the decisions, help inform our interventional teams and help support our interventional teams in advance of their intervention. I think that the time to diagnose left main disease isn't by surprise in the cath lab. Obviously, left main disease, as I showed you from the ischemia trial, good correlation with invasive angiography, and the discordances were modest, usually across the cut point. But I think to diagnose critical distal left main disease, I would not want to be doing this with a catheter in the left main. The time to do this, of course, is non-invasively in the CT lab, inform the interventional team, have a discussion with the surgeons, have a discussion with the interventionalists, and then they can then go to the cath lab with a plan, or perhaps even consider for intention of stenting, or consider coronary bypass referral. Finally, as it relates to physiology, I think this is another opportunity to inform these decisions. You know, anatomy was something that when we could offer our interventionalists, they sort of said, well, okay, I get it, but, you know, I'll do an invasive angiogram and my anatomy will be better than your non-invasive anatomy. So, you know, we'll just figure it out, Jonathan. But once we start exploring the opportunity to get 3-vessel non-invasive physiology non-invasively in advance of the cath, I think our interventional colleagues started to really understand this is something that could really help them. And this is what we saw in the Syntax 2 trial from Professor Sorois and Carlos Collet. If we look at the non-invasive anatomical syntax, the disease, the syntax score was overestimated non-invasively as compared to the invasive gold standard. CT is good on a per patient basis and provides an understanding of anatomical disease extent, but once you get very complicated disease, chances are we're overestimating in particular calcified lesion stenosis. But when we looked at the non-invasive functional syntax score between CT FFRct and compared it to the invasive gold standard, you can see the agreement was very high. Importantly, though, this non-invasive roadmap could be achieved before the cath lab without having to do 3-vessel invasive physiology, which is time-consuming and comes with risk and cost. So I think to provide this anatomical functional roadmap is a unique opportunity to inform not only the decision about whether or not to go to the cath lab, but to help inform what the interventional is likely to find and help inform decisions around revascularization before the cath. Here's an example: critical LAD lesion, severely abnormal physiology. You may say, well, that's a 90% LAD lesion. They're going to stent it anyways. But how about the moderate right coronary lesion? Instead of sending the patient to the cath lab saying, good luck, figure it out, I don't know if the right lesion needs to be stented, we can provide that anatomical and functional roadmap highlighting that the LAD needs to be revascularized, severely abnormal physiologically. The right coronary, on the other hand, has negative physiology. The right coronary doesn't need to be wired. The right coronary doesn't need to be stented. And your interventional colleague can go with a plan in advance of the procedure to stent the LAD and leave the right coronary alone. And here's the corresponding invasive FFR, which is, of course, not playing, but negative in this case. And the last thing I want to highlight, where I think is a real opportunity to not only use CT FFRct to decide whether or not to send the patient to the cath lab, but to really help our interventional colleagues the way we have in the structural space, is helping them understand the complex phenotypes of physiology. We've seen very nice work from the resting physiology groups, the IFR groups in particular, looking at non-hyperemic pullbacks, looking at the phenotypes of physiology using resting physiology. And here I highlight hyperemic FFR with a mechanized pullback from Bernard de Bruyne and Carlos Collet. And what you can see here is angiographically, we have 3 angiograms that to my non-trained eye are very hard to discriminate. They do physiology, and you can also see that in the distal vessel, they all have abnormal physiology. But you can appreciate when you do this pullback, the phenotypes of the physiology are very, very, very different. If we see on this case, on the x-axis is the length, the y-axis is the FFR. This patient has a very focal phenotype. The pressure is normal, there's a focal lesion, the pressure drops precipitously, and that's over a very short length. This is a lesion that almost certainly will derive benefit from revascularization. There's tremendous translesional pressure loss, there's very abnormal physiology, and it's very focal. On the other hand, here's a case of a diffuse pattern. The pressure in the distal vessel is below 0.8. It's abnormal. But look at how the pressure dissipates. It dissipates very slowly over 10 centimeters of length. These are patients that are very difficult to manage with focal percutaneous treatment. Not saying whether they should or shouldn't be, but I think it does highlight some interesting opportunities to go to the cath lab with a plan, understand what you're going to be tackling, and at least go in with some expectations and understanding of what it is you're going to be faced with the very next day. And you can see that we can do this non-invasively. Again, this is from the team from Ulst. You could see this sort of very diffuse pattern versus the very focal pattern. This lesion very treatable. Almost certainly this patient will derive a symptom relief benefit and perhaps an MI reduction benefit from revascularization. On the other hand, this anatomy is very challenging to treat focally. And to highlight that, just one last case from the Precise P3 trial, which will be, I believe, presented at ACC this year. You could see this patient has diffuse atherosclerosis, extensive plaque, non-calcified plaque, very long lesion across the LAD. And you could see from the FFRct that the pullback would suggest that the physiology is abnormal, but it drops very slowly across the entire length of the vessel. And look at the invasive gold standard. What did they find? Almost the exact same. Very slow, progressive pressure loss across the LAD. You can have this, though, not only by doing this complex invasive hyperemic pullback, which takes a lot of time and expertise, but we can actually potentially offer this non-invasively in advance of the procedure. And why would this matter? Well, let's look what happens when they revascularize PCI, this very complex diffuse phenotype of physiology. They do this complex revascularization, and look what happens to the physiology. Almost no movement in the physiology, highlighting the fundamental challenges of percutaneous focal intervention of a complex diffuse phenotype of physiology. Again, I don't have definite evidence that suggests that this revascularization will not have benefit for this patient. Obviously, we wait for studies like DEFINE GPS, but I would posit to you that having that information before the cath lab would almost certainly be of value for our interventional colleagues so they can better understand the patient-specific anatomy and physiology and inform their decisions around revascularization. So I'll close there. I hope that was of interest. There are many, many outstanding challenges. There's so much more to talk about, obviously, as it relates to coronary CT. A lot of the work that I've seen as it relates to extracellular volume adjudication, things like understanding also T1, equivalence of T1 mapping, work that's being done by the team from Cedars, opportunities around plaque and perivascular fat inflammation. But I wanted to at least highlight some opportunities about CT planning intervention and the potential opportunities with the complementary role of physiology. Thank you again.
Thank you very much. That was an amazing talk as always. For everyone, there's a lot of attendance, high attendance. So please put your questions in the Q&A and we'll go through them one at a time. I'll start with a question. I think it's very interesting how you define atherosclerosis with FFRct extra and the diffuse plaque. Is there any value for measuring progression of FFRct in relation to progression of atherosclerosis and medical therapy?
You know, this is a really great question. You know, I think this is a fascinating area, obviously, as it relates to titrating medical therapy, understanding patient-specific phenotypes of atherosclerosis, and then physiology. I know of a couple of studies. I know the group from Lundquist for, UCLA Harbor, Matt Budoff's lab, is looking at this. And I know there are a number of other studies that are looking at novel anti-atherosclerotic agents or atherosclerosis management agents, and looking at also physiology and FFRct. There's certainly, we don't have any prospective data to support that, but I think it could be a very stable measure, particularly that nadir value, that low value. And then I'm excited about exploring with many people this coronary volume to mass as a measure of vascular health. Can the coronary volume to mass actually improve with exercise? Can it improve with cardiac rehab? Does it improve with plaque stabilization and regression? I think these are all the questions that we need to continue to explore. I think we need a lot more evidence, to be honest with you, for that matter, to use CTA even in follow-up routinely, looking at plaque. I know there's obviously a number of tremendous plaque softwares, including AutoPlaque and Metis, and now there's facilitated algorithms that are coming. But, I think we need to understand what role serial CT will have for the individual. I think that the data that I've been privy and privileged to be part of, I think really helps as it relates to population-based signals of, drivers of progression, helping understand why patients progress, what patterns of progression across a population may be associated with risk. But we know that as we're doing serial CTs, there's still a lot of challenges as it relates to tube energy, as it relates to contrast injections, and making sure that we can really robustly and routinely extract these data to inform patient-specific decision-making. So I think the whole field it's really an exciting area, but we all have to work together to generate more evidence, I think.
Okay, great. I think we have a first question from Yuka from Cedars. Do you have any cutoff for delta FFRct to suggest focal ischemia?
Yeah, it's a great question, Yuka. Nice to hear your question. There's another Japanese physician, very smart physician named Takagi, who's with us here in Vancouver, and he published a nice paper while he was in Iwate, Japan, and he proposed a delta FFRct of 0.12. He's actually looking at the advanced registry to see if that measure holds true. We know that value is actually the same value that we saw in the Emerald study as it relates to risk of instability of plaque and downstream myocardial infarction. So I think that there's two reasons why one wants to consider adult FFRct. One, because I think it's a crude measure of focal, that focal endotype of physiology. That's the lesion that's like the interventional is, it's a softball, as we say, it's right, it's perfect for them to really, it's a focal lesion, it's causing a lot of pressure loss, it's likely easily treatable percutaneously. And I think the other reason is, at least there's some evidence to suggest that that's a measure of axial plaque forces, which may, in combination with many other factors, help us better refine our understanding of which lesions are at higher risk as well. And maybe that's why leaving, abnormal physiology, particularly with high deltas, may be leaving patients also exposed to high incidence spontaneous MI rates. So the 0.12 is kind of what we've settled on now. We clearly need more data.
Great, thank you. There's another question here from Vikram from Monty. It says, what are your thoughts on the SPIN's cost for effectiveness study for stress MRI, which showed acceptable cost quality in the US health system? Is there a role for stress MRI as a first-line test?
Listen, I've learned a lot from a lot of people over the years, but about a decade ago, I remember sitting with people like Dan and James Min, Jamin, and others, and they reminded me as clinical cardiologists that you should use a test to answer the question at hand. And I think that stress CMR, obviously there's amazing work that's being done in many centers in the UK and beyond. But I think personally, fundamentally, I don't know, in someone without known coronary disease, how I would feel comfortable really actioning based on that without knowledge of their atherosclerosis, right? I think fundamentally knowing whether we could get quantitative plaque, I think this would be super exciting. But even on a crude level, I mean, from Jim's paper from 2007, the first one on prognostication, segment involvement score, or the calcium scores we saw in the West Danish Heart Registry, published in 2020 by Bjarne Norgard and Dr. Mortensen. You have more plaque, you have more events. So, stress CMR telling me that that there's no perfusion abnormality without telling me how extensive the plaque is, I think would be a missed opportunity personally. I can't see it, and certainly not in our healthcare system. Where stress CMR, we have limited access to MRI and challenges as it relates to that. So,
great. I think I'll do another question while we wait. Could you comment on the ethnic changes in FFRct in different ethnicities?
Yeah, I think there needs to be a lot more data there. So a quick answer could be, I don't know a lot about it. I know there's work coming from Brian Coe and the team looking at some measures as it relates to their very cosmopolitan population in Melbourne, looking at coronary volume to mass in particular. I think that's interesting. I think that there's some data that relates nitrate response to, or ethnicity to nitrate response. So I think that inherently is a measure that we should probably look at and that we're ignorant to. And then I think it's an opportunity to explore with a lot of the CT data sets we have. So there's evidence that South Asian patients may be more, have a muted response to nitroglycerin, not all, but some. So I think these are real opportunities to explore that. We've learned a lot from the CT world over the years, from the CONFIRM registry and from other studies that have been published looking at ethnic differences. So I think that's absolutely a real opportunity.
Great, and I think there's no more questions. I'll do one more before we close. And could you comment a little bit more in patients at triple vessel disease that we will decide on conduits for bypass surgery? Are we there yet to decide whether the patient needs a vessel revascularized, or should we make that decision based on FFRct?
Yeah, well, there is a study that's the rationale and design paper has been published by Professor Soroy's in BMJ Open, I believe, called Fast Track Cabbage. It's being looked at to see to really evaluate the feasibility of a non-invasive assessment to help guide the decision making around bypass. Obviously, we don't have any that sort of feasibility. It's a feasibility study. There's certainly no randomized data. I think it's exciting and it's really fascinating to see this trial evolve, but I'll obviously wait on that data to comment further.
Great. Well, that was an amazing talk. Thank you very much for joining us, and we'll see you soon in person.
Thank you. I wish everyone nothing but good health and continued safety, and look forward to seeing you all soon, I hope.
All right. Thank you very much.
Well, Leandro, thank you for the invitation.